given magnesium sulfate for eclampsia and tocolysis, and they found that there was a significant reduction in the rates of cystic periventricular leukomalacia and cerebral palsy in those born to these mothers. And since then, we have had 5 randomized controlled trials, 3 meta-analyses, and the evidence of the top notch, which is the Cochrane review. Cochrane review had 5 trials, which included almost 6,145 infants, and they categorically have stated that magnesium sulfate therapy given to women at risk of preterm birth with the neuroprotective intent substantially reduced the risk of cerebral palsy with the relative risk of 0.68. Now, they found that there is significant improvement in the rates of cerebral palsy, combined death and cerebral palsy taken together as a modality, and a reduction in substantial gross motor dysfunction. Gross motor dysfunction basically means that it's the ability of a baby to walk without assistance. And they also found with the Cochrane review that there was no significant improvement in intraventricular hemorrhage, periventricular leukomalacia, blindness and deafness, and of course developmental delay. Now the mystery has finally been unveiled on how magnesium would act. They have looked at and found out that the most commonest pathological lesion that is found in a preterm baby with cerebral palsy is periventricular white matter injury, and we understand that oligodendrocytes are probably the major glial cell population that we have in the white matter. There are some N-methyl D-aspartate receptors on these oligodendrocytes, neuroprotective agents, and we find that magnesium does just that. Now, magnesium also works as a calcium antagonist, as we all know, reducing the calcium influx into the cells. It also provides a lot of tissue protection for in terms of glial cell injury from a free radical injury. It does reduce vascular instability. The vasodilatory role has a very important one to play. It does attenuate cytokine-induced cell damage, and it has got an anti-apoptotic function too. How much and how long? Very similar to the intravenous regimen that we use for eclampsia. 4 grams of intravenous loading dose given slowly over 20 to 30 minutes, followed by a 1 gram per hour IV infusion as the maintenance dose. Continue until birth or for 24 hours, whichever comes first. And if you are planning for an elective delivery, which is going to be timed like a planned cesarean. Now, if an urgent delivery is indicated for fetal or maternal reasons, do not delay the delivery for the purpose of administering magnesium. At present, there is no supportive evidence for the repeat dose, so it is probably left to the discretion of the caregiver. How to monitor the mother? We know very well how to monitor a mother on magnesium, checking the pulse, blood pressure, respiratory rate, and fetal neuro-protective for the loading dose 10 minutes after starting, and probably at the end of the loading dose, because for a duration of around 20 to 30 minutes, and stop if respiratory rate decreases by 4 breaths per minute, or it reaches a value of below 12 breaths per minute. Or a fall in diastolic beat of more than 15 millimeters of mercury below baseline. Serum magnesium concentration, we know that it need not be routinely monitored, needs to be looked at only for a woman with a renal compromise. There is a potential theoretical interaction between magnesium sulfate and nifedipine that is often hypertension and neuromuscular blockade, but in practice, thankfully, it hardly ever exists. And why it has been a thumbs down for magnesium as a neuroprotection till now? A data from one of the scattered studies have shown that there was some amount of adverse neonatal outcomes because of hypomagnesemia, hyporeflexia, and respiratory depression, leading to the requirement of mechanical ventilation, and probably also because of the larger numbers needed to treat when compared to steroids. If you look at the effect of steroids, the NNT would be somewhere close to 9 to 11 when you are talking about respiratory distress syndrome or intraventricular hemorrhage, but here the numbers are close to 40 to 60 when you are talking about a combined modality of death and cerebral palsy or cerebral palsy taken as a single indicator alone. So probably it has been because of the larger NNT too focused on giving magnesium as the neuroprotective agent. Now why it needs to be a thumbs up for magnesium? Because the neuroprotective effect is significantly more rapid, unlike steroids, because you hardly require 4 hours if your delivery is going to be a planned one. And it's a very, very familiar drug in obstetric practice, so you hardly require any extra thing for your personal or for yourself. Benefit is very clear with evidence from the top notch, which is the Cochrane review. And the researchers also say that more superior evidence is quite unlikely in the near future because it has already been quite extensively studied with the 5 hours that we already have. Now probably that's the story about magnesium, and most of these kind of lectures end up with the audience opting for the best mode of neuroprotection, which is to have a good sleep. And we hope that I have not taken you to such a stage. Thank you so much for a very patient listening. You have been wonderful.